The two prerequisites for a marketable vaccine are that it is safe and effective. Vaccines that are based on inactivated virus particles or immunogenic viral proteins must not contain infectious particles or viral nucleic acids, respectively. If a replication component vaccine is used, virulent revariants, which the vaccine strains mutate back to a pathogenic phenotype, must be exceedingly rare. In addition, there can be no contamination of vaccines with other microbes introduced during production. These objectives may seem obvious, but given the potential for human error and the scale at which vaccines are synthesized, absolute safety is hard to accomplish and impossible to guarantee. Furthermore, when rare side effects do appear, they are often identified only after millions of people have been vaccinated. In addition, intuitive replication component vaccines have the potential to spread to individuals in a population who have not been vaccinated. For this reason, the smallpox vaccine is not recommended for immunosuppressed individuals because of adverse outcomes of vaccine-associated infection. To be effective, a vaccine must induce protective immunity in a significant fraction of the population. Not every individual in the population must be immunized to stop viral spread, but the number must be sufficiently high to impede virus transmission. Person-to-person transmission stops when the probability of infection drops below a critical threshold. This effect is called herd immunity. To appreciate the importance of this effect, one might consider the likely outcome in two hypothetical elementary schools, each with 500 students. In elementary school A, all but 10 students have been vaccinated against measles virus, whereas in school B, only half, 250, have been vaccinated. Most would intuitively and correctly judge that an unvaccinated child is much less likely to become infected with measles virus in school A than in school B. This is true because 490 vaccinated students in school A provide immunological wall around the unvaccinated children. In school B, fewer children are vaccinated, and so the wall is leakier. Consequently, there are more opportunities for the virus to gain a foothold in this population and to be transmitted among those who have not been vaccinated. The actual calculation for herd immunity is pathogen and population specific, but generally corresponds to 80 to 95% of the population acquiring vaccine-induced immunity to provide protection to all members of the community. No vaccine is 100% effective in a population. Consequently, the level of immunity is not equal to the number of people immunized. In fact, we know that when 80% of the population is immunized with measles vaccine, about 76% of the population is actually immune, clearly well below the 93 to 95 required. Obviously, achieving such high levels of immunity by vaccination is a daunting task. Moreover, if the virus remains in other populations or in alternate hosts, reinfection is always possible. In closed populations, vaccinations of individuals with larger or less controlled populations in widespread areas present serious logistical challenges. In addition, public complacency or reluctance to being immunized is dangerous to any vaccine program. The publication of a widely criticized report purporting a link between measles vaccination and children's autism led to reduced vaccination coverage in particular populations in the United States and Europe, leading to frequent measles virus outbreaks that continue to this day. Despite the article being discredited some years ago, the consequences extend beyond vaccination rates. This article triggered an erosion of the public's confidence in vaccine manufacturers and providers. The protection provided by a vaccine must also be long-term, ideally lasting for the balance of the recipient's lifetime. While some vaccines cannot provide lifelong immunity after a single administration, subsequent inoculations, or what we call booster shots given after the initial dose, can stimulate waning immunity. However, this practice may be impractical for administration to large populations and can pose serious record-keeping challenges in resource-poor areas. Mounting the proper immune response is also the key to durable immunological memory. For example, Primary infection by some viruses, such as poliovirus, can block only when a robust antibody response is evoked by vaccination. Alternatively, a potent cellular immune response is required for protection against herpes viral disease. To maximize the effectiveness, a vaccine must elicit the same type of immune responses as the natural virus infection it is designed to prevent. Outbred populations have varied responses to vaccinations. Some individuals are protected, while others may not respond as well or poor take. Although many parameters influence such variability, the age and health of the recipient are major contributors. For example, the influenza virus vaccine available each year is far more effective in young adults than in elderly, likely due to the decline in production of the new immune cells and reduced effectiveness of existing immune cells in aged individuals. Poor immune responses to vaccinations pose serious problems. Obviously, protection against subsequent infection may be inadequate. In addition, as discarded previously, should infection with poliovirus vaccine reverts then occur in an immunosuppressed host, mutants that can escape the host immune response may be selected, posing a risk to others within the population. Once safety and efficacy are assured, other practical requirements including stability, ease of administration, and cost must be considered. If a vaccine can be stored at room temperature rather than refrigerated or frozen, it can be used where cold storage facilities are limited. Appropriate storage is particularly relevant for intuitive vaccines. One of the abiding challenges of measles virus eradication is that a vaccine, which is a replication component intuitive virus, must be kept cold from its synthesizing to inoculation in the recipient host, which they call the cold chain. Failure to keep the vaccine cold inactivates the intuitive virus and greatly weakens its ability to induce immunity. In countries where electricity is not reliable, lack of refrigeration poses a substantial obstacle. But the science and engineering community loves a challenge. The Gates Foundation supported the development of new thermoses that can keep vaccines frozen for more than a month without the need of electricity. Creative, multidisciplinary solutions will be critical to solve the practical challenges of worldwide vaccine. The route of administration and cost per dose are important considerations as well. When a vaccine can be administered orally rather than injection, it will likely be more widely accepted and certainly far easier and faster to deliver. Cost is perhaps the biggest challenge. The World Health Organization estimates that a vaccine must cost less than $1 per dose if global control is to be achieved, but research and development costs alone for modern vaccines are in the range of hundreds or even millions of dollars. This sum does not account for the manufacturing costs or the prohibitive expense of liability coverage for the vaccine producer. Liability expenses can be astronomical in litigious societies, forcing many companies to abandon vaccine development completely. Ultimately, economics is a powerful driver of which vaccines make it to the market. Vaccine developers expect a good return on its investment. But of 10 those individuals and government agencies who are most in need are the least able to pay for them. The circumstances underscores the crucial contributions of non-governmental organizations such as the Red Cross, the Global Vaccine Fund, and others in ensuring effective and economical vaccine dispersal.